Good morning, everybody. It's wonderful to be here, and particularly after a riveting panel discussion, it's also very interesting for me to speak to you about mental health and diabetes. Chennai always welcomes me a lot, and Dr. Vijayakumar, who's more than a friend, has just given me a jacket to control the cold that I was feeling in this air condition. This is the kind of affection that he has for me, and this is why I so love coming here. So we're going to be talking about mental health and diabetes, and I think the first thing that we need to discuss today is how many of us actually discuss mental health with our patients. I, for my part, in all my years of practice, both in the Western world and in India, if somebody starts talking to me about a mental health issue, I actually switch off. But there is little doubt that mental health and diabetes are very strongly together, and this has been described for ages. And there's this quote by Henry Maudsley that diabetes is a disease which often shows itself in families in which insanity prevails, and this is going back to 1879. So this is how long the history of diabetes and mental health is. And diabetes has many psychiatric associations, primarily depression, also anxiety disorders, feeding and eating disorders, as you would intuitively believe, and schizophrenia and other psychotic disorders. So mental illness increases the risk of diabetes and its complications, and as you would feel automatically that with mental illness there is the non-adherence to medication and self-care, there is functional impairment, there is a risk of complications which leads to increasing healthcare costs, and also a risk of early mortality. The primary cause of the mental problems is, of course, depression, which afflicts 60% of type 2 diabetics. Now, there is a strong interplay between diabetes and major depressive disorder and other conditions. And if you look at major depressive disorder at the center, there is a reciprocal susceptibility with diabetes, which is also related with bipolar and other related disorders and schizophrenia spectrum disorders, which in turn increase the risk of suicide and post-psychotic depression. Also, there is a link with generalized anxiety, stress, feeding and eating disorders. You know, a lot of our patients with diabetes are obese or very slim, and this might be one of the reasons for it. And this also leads to sleep-wake disorders and also maladaptive personality traits or disorders. The primary problem that I think most of us see on a day-to-day basis is anxiety. And patients have this huge fear of injections. I'm sure all of us who treat diabetes have this huge number of patients who have this fear for injections and fear of hypoglycemia. Particularly, you will find patients of your type 1 diabetics particularly very fearful of hypoglycemia, particularly the parents. And of course, we have to remember that the symptoms of anxiety that we have, shaking and trembling and palpitations, feeling sweaty and nervous, these are also features of hypoglycemia, and we must be careful to differentiate hypoglycemia from features of anxiety. Eating disorders occur predominantly in women. Now, this is not a sexist comment, but psychiatric disorders of diabetes are primarily seen in women. In fact, eating disorders are not particularly described in men at all, particularly if they have diabetes. And about 40% of people with type 1 diabetes, 40%, which is 4 in 10 people or 2 in 5 women in the age group of 15 to 30, have binge eating and caloric purging through insulin restriction, because insulin tends to make you put on weight. And this disordered eating behavior persists and worsens over time. It does not get better as women get older, and this in turn leads to poor glycemic control, increasing rates of hospitalization, higher microvascular complications, and not only that, premature death is more common in women with type 1 diabetes who have eating disorders compared to women who do not. So it is a very serious illness. The other illness, I'm going to come to depression at a later stage because I'll be showing you some Indian data that we have on depression. So that is why I'm coming to depression at the very end. schizophrenia and diabetes, schizophrenia is associated with a 2 to 3 times higher level of diabetes than the rest of the population, particularly low socioeconomic status. In drug-naive people with schizophrenia, evidence shows that they start with an increased risk of developing diabetes, and this in turn leads to poor lifestyle, poor nutrition with a high-fat diet, lack of exercise, smoking, etc., and they have a family history of diabetes. And I think we can take this back to Henry Maudsley in 1879, who actually said that there is diabetes in the family of people who have insanity. And there is an overlap between genes. A lot of genes have been isolated, which can be traced back to both schizophrenia and diabetes. We have to remember that schizophrenia needs treatment with conventional and atypical antipsychotics, and these in turn have very toxic metabolic effects, both in terms of body weight, glycemia, as well as lipid abnormalities. And this is why people with schizophrenia have a very high mortality rate. They die mainly from cardiovascular disease. It is early death, and there is very toxic complications that we see in people with schizophrenia who develop diabetes. And there are various links between diabetes and schizophrenia. Primarily, it is the genetics which leads to the development of schizophrenia. Drugs as well as lifestyle changes lead to worsening of the metabolic situation. The metabolic milieu inside the body worsens, and there is earlier development of diabetes and complications. Again, going back in time, phenothiazine use increased the prevalence of diabetes from 4.2% to 17.2% in 1968, and ketoacidosis was reported with clozapine and clonazepam. Just the day before I came to Chennai, that was last Saturday, I saw a gentleman who has been on olanzapine for mild depression come to me with a blood sugar which was 785. Not known diabetic, no family history, 27-year-old gentleman. And, you know, this is the kind of toxic effects that antipsychotic drugs have. So it is extreme. It can lead to HHS or ketoacidosis, and these are particularly true of atypical antipsychotic drugs, and they are not particularly toxic to the islet cells, but because of the weight gain that they generate and because of the worsening of the lifestyle, there is increasing insulin resistance, with clozapine and olanzapine being the worst, and ziprasidone, which is not particularly available in much quantities in India, being the best. The mechanism is probably related to alterations in the hypothalamus, and there have been a lot of studies now with metformin and GLP-1 RA which have been used as a treatment for these metabolic abnormalities. In fact, the NICE guidelines have started suggesting that you start metformin whenever you start patients on atypical antipsychotics. The NICE guidelines have showed papers which actually show a reduction in body weight, improvement in lipid parameters, and an improvement in glycemia in patients who go on to drugs which are antipsychotics when they start with metformin. So these are the summary of the drugs. Clozapine, olanzapine are the most toxic, with the worsening of weight gain, risk for diabetes, and lipid profile worsening. Weight gain increases seen with risperidone and quetiapine. Diabetes and lipid profiles remains debatable. Aripiprazole and ziprasidone seems to be the best of the lot. Ziprasidone has the best data as far as weight is concerned. Most second generation and first generation antipsychotics are toxic. There is weight gain, and this is not only seen in adults. I will show you some data in children, that there is increase in weight in all populations. So if your patient actually has a metabolic decompensation, it is probably best as a diabetologist that you suggest to your psychiatric friend that they try and stay away from these second generation and atypical antipsychotics and go to some older form of drugs, at least till they get good glycemic control, by using drugs like, say, haloperidol, okay, which are older but are safer from a metabolic point of view. Children also, as you can see, olanzapine, quetiapine, risperidone, aripiprazole, there's about a 10 kilogram weight gain. Huge weight gain that you see in children with using these antipsychotics. So it is imperative that if you patients are taking antipsychiatric medicines, they need regular metabolic screen. This is from the Canadian guidelines, where you check for weight, you check for waist circumference, you check for blood pressure, fasting plasma glucose and A1C, lipid profile, counsel about tobacco use and family history, and you do checkups of weight every 3 to 6 months. Waist circumference, blood pressure, and A1C should again be checked every 3 to 6 months. And this is something you should monitor in your patients who are taking these drugs. Moving briskly on to the main focus of my talk, which is depression. Depression is seen in 30% of people with diabetes, 10% have type 2 diabetes, leads to lower levels of physical fitness, reduces medication adherence, and is associated with a high risk of complications. The link probably is a lot of things. Innate immunity and inflammation, along with stress of depression causing HPA axis dysregulation, which in turn is from in utero stress in nutrition and unhealthy lifestyles, and also genetic factors, childhood adversity and adult adversity, lead to worsening of insulin resistance, beta cell apoptosis, hippocampal atrophy, endothelial dysfunction, circadian rhythm disturbance, and worsening of type 2 diabetes, cardiovascular disease, dementia, and depression. And it was very interesting when Dr. Usha Sriram did her talk this morning that she saw gestational diabetes is associated with an increased risk of depression following delivery, which is also something that would be in keeping with the pathophysiological trend which has been described in the Lancet. Now, the diabetes should be screened for depression and anxiety symptoms. This is where we need to change our clinical practice. There are diabetes specific and depression and quality of life specific screening tools. These are free. You do not have to buy these tools. They are available online. I think it is coming to a stage when 30 to 40% of our patients have diabetes. We should be looking at diabetes as as depression as one of the comorbidities of diabetes, like we look for macrovascular disease and microvascular disease. Yes, we should be taking time out to be looking at psychiatric problems, and I will show you what it actually means. Diabetes distress is something that needs to be dissociated from diabetes depression. There is emotional turmoil and despondency, specifically related to caring for diabetes and the need for monitoring and treatment. Again, just a couple of days back, somebody came to see me, young lady, just been diagnosed as having developed diabetes. And she kept on asking me that, doctor, is this permanent? Doctor, is this permanent? Or is it just a short-term thing? And when finally I did manage to get through to her saying that this is a permanent disorder, she broke down and started crying, saying that I can't believe that this kind of a disease can be happening to me. And indeed, the diagnosis of diabetes, though we here in India have started dealing with it as a statistic, is actually a shock and reason for despondency and distress in a lot of people who get diagnosed with this condition. And this also in turn is related to insulin usage, and people feel that diabetes means usage of insulin, and it means a failure, it means pain, it means loss of control over their lives and loss of a personal life because insulin is being initiated. So diabetes distress has to be differentiated from major depressive disorders. There are scales which you can use. I will show you the scale later on. Self-report, emotional burden, symptoms have to be differentiated accordingly. Also, behavioral symptoms need to be looked at. And indeed, if you can have a psychologist at your premise to provide these kind of services, it does a world of good. We did this in a kind of pilot scheme. I shall be showing you data on that. And this seems to be a wonderful way forward. So the treatment options for depression are CBT, psychotherapy and antidepressant medication. So one of the examples of cognitive behavior therapy is how you can manage the fear of hypoglycemia, whereby you determine the actual versus perceived frequency and severity of hypoglycemic episodes and ask the person about his or her concerns in developing these hypoglycemic episodes, normalize the fear response, empathize, ask for permission to look at the possibility of reducing these problems, ask the person how fear and anxiety has been overcome in certain situations, determine the person's comfort zone, and use a gradual approach to nudge the patient psychologically to a safe glucose zone. There are people who will say, no, I'd rather have a blood sugar of 250 than have a hypoglycemia because it makes me feel so awful. And this is where we need to go in for counseling, where we need to go in for CBT and reduce this. And these are the features of cognitive component and behavioral component of therapy where we can actually treat our patients and improve their outcomes. The next slide, these are all the drugs that have been studied for the management of diabetes: paroxetine, nortriptyline, fluoxetine, sertraline. All antidepressants have been looked at. Very busy slide. All I'll say is all of these drugs help, particularly if you have mild to moderate depression. Difficulty lies if there is severe depression and diabetes, in which all the drugs show very modest results. Glycemic control is not worsened by any of these drugs. And this will take us on to the two pieces of data that our group has generated. It's in press now, but they have been looked at as posters at the ADA last year. And the assessing prevalence and predictors of depression in type 2 diabetes, the DEPDIAB study as we called it. We recruited 1,371 type 2 diabetes with diabetes more than 1 year, and we had a cross-sectional survey for depression by looking at the PHQ-9 and the Beck depression scales. These are very well validated scales which are available online, and you don't have to buy them. About 60% patients were male and 40 female. 56 patients met the criteria for severe or moderate depression, 4.1%, and 36% mild depression, which is slightly more than the worldwide reported average of 30%. So our data shows a 40% risk of depression in diabetes. And of course, as you would expect, 60% of patients did not have depression. This is the questionnaire. This is what is available. I'm sorry it's not projecting very well because I think it's been changed to 16:9. But whatever it is, this is the questionnaire. We also took anthropometric data. We also took data like HbA1c, urinary ACR, retina, and we also looked at data from history of strokes and bypasses and coronary artery disease. And the exclusion criteria were people who were known to suffer from depression. So if you had depression or you had documented psychiatric illness or you were on psychiatric medications, you were taken out of the study. And initially we had looked at about 1,500 or about 1,600 patients, and 1,371 could be included for final analysis. And only the people who had full follow-up were the people who could be analyzed for the study. And this is the important factors that we looked at. We've shown you the prevalence of depression, and these are the age group, gender, low economic status, and upper class, compliance, hypoglycemia, insulin use, ADL, difficulty versus no difficulty, comorbidity. These were the areas that we looked at. So this is by distribution of depression by age group. Interestingly, though, the age group of 18 to 40 years constituted only 11% of the cohort. It accounted for the highest prevalence of depression. It was moderate in middle age group of 41 to 60 and least in older age group. So statistically, depression was noted to reduce with advancement of age. A linear trend was observed, and this is statistically significant. Then we look at it again, as I said before, depression is more common in women. This is again statistically higher in women than in males. And we looked at the socioeconomic scoring, which is the Kupuswamy socioeconomic scoring. And again, there is a linear trend showing significant difference As you know, so the lower the socioeconomic status, worse is the depression, and depression tends to reduce as the socioeconomic status improves. There is no correlation of depression with duration of treatment. So even if people have had longer progression of disease does not in itself precipitate depression. Compliance of medicines, if you're less compliant, there is worsening of depression, or you could interpret it the other way around, that people who are less compliant are more likely to be feeling depressed, probably as a burden of the disease, probably because they're not taking the medicines because they are feeling depressed. There is no correlation of depression with glycemic control. And what is interesting, there is no correlation of diabetes with insulin therapy. I think this is where comes into the focus of diabetes distress. So the people who are going on to insulin who feel sad and despondent are probably suffering from diabetes distress, which is why they do not qualify as having depression according to the PHQ-9 questionnaire. So this is a very interesting piece of data, but people who have hypoglycemia, we describe hypoglycemia as one episode in which the patient felt symptoms, no CBG recording, but had to take help of somebody else. So episode where help was required, a severe hypoglycemia, and this in turn led to almost 2 times higher risk of depression, of diabetes, of depression thereafter. There was no correlation with depression and any of the complications, including retinopathy and blindness. There was no correlation, but people who could not perform their activities of daily living convincingly, they seem to be doing worse off with diabetes and depression. Hospitalization had no correlation with this depression. So we concluded the following things, that there was a 40% increased risk of depression. 40% of our patients suffered from depression. More commonly seen in young age and female sex. Direct correlation with lower socioeconomic status. And this could partially be explained by the fact that poor socioeconomic status served as a hindrance to satisfactory glycemic control. No statistically significant correlation between poor glycemic control and depression. Hypoglycemia was an independent variable. Depression was positively associated. Presence of comorbidities, including retinopathy, did not contribute to depression in this cohort. Presence of depression affected activities of daily activity. Incidence of hospitalization and had no statistically significant correlation. I think this is the first data generated from India where we've looked at diabetes and depression in so much of detail, particularly looking at things that might affect depression and diabetes both at the same time. So we also looked at, from this data that we generated, we also looked at suicidal ideation, and this was seen in 15% of people with diabetes. And as you can see, again, there was an inverse relationship between socioeconomic status and suicidal ideation, the most being amongst the lower class of socioeconomic status, and the upper classes having the least amount of suicidal ideation. Recurrent hypoglycemia was associated with suicidal ideation, and as you can see, it was extremely high, to the tune of about 20% of people who had recurrent hypoglycemia had suicidal ideation. And poor glycemic control also accounted for increased risk of suicidal ideation. So we concluded that suicidal ideation is not common. It is worse in the socioeconomic status which are lower, and those who have frequent hypoglycemic episodes and suboptimal glycemic control. Assessment of suicidal ideation should be a part of the clinical assessment. And again, I hasten to add that this is an area of diabetes that we are not looking at in much detail, and we really should be changing our clinical practice. Statistically, suicidal ideation and duration of diabetes was not associated, and not with diabetes duration. It did not correlate with presence of comorbid illness, hospitalization, BMI, and insulin usage. This data again shows you that there is a higher incidence of of suicidal ideation in people from India. And again, I think this is the first generated data which we hope to publish very soon on this aspect of healthcare in diabetes. Thank you, ladies and gentlemen, for your kind patience.